Fatty liver disease. So there are different diseases. It could be alcoholic liver disease, non-alcoholic liver, uh, fatty liver disease, and non-alcoholic steatohepatitis. So alcohol liver disease, there is a significant alcohol consumption, more than 21 drinks per week for males and more than 14 drinks per week for females. Non-alcoholic fatty liver disease is steatosis without hepatocyte injury. Non-alcoholic steatohepatitis is steatosis with inflammation and hepatocyte injury with or without fibrosis. Alcoholic liver disease is 15 million people who abuse or overuse alcohol in USA. 90% of those will develop fatty livers. Moderate use with another risk factor. Non-alcoholic liver disease, the most common chronic liver disease in USA. Fourth most important common reason for liver transplant, projected to be the most common in 10 to 20 years, up to 20 to 40% in adults and 6 million children. Natural history of fatty liver disease. Fatty liver steatohepatitis, steatohepatitis with fibrosis, steatohepatitis with cirrhosis, and cryptogenic cirrhosis. Risk factors including the middle-aged, female gender, overweight or obese, mild hepatitis, iron overload, medications, rapid weight loss, starvation, refeeding syndrome, Reye's syndrome. Autoimmune diseases, malnutrition, A beta lipoproteinemia, overgrowth of bacteria in small intestine, TPN, acute fatty liver of pregnancy, HELLP syndrome, Hispanic ethnicity, and hereditary. Risk factors established association include obesity, type 2 diabetes mellitus, dyslipidemia, metabolic syndrome. Emerging association is with polycystic ovarian syndrome, hypothyroidism, obstructive sleep apnea, hypopituitarism, hypogonadism, pancreatic duodenal resection. Risk factor in medications include amiodarone, methotrexate, tamoxifen, corticosteroid, diltiazem, valproic acid, highly active antiretroviral therapy. Screening considerations include liver biochemistries can be normal, ultrasounds are expensive, general population screening not recommended, undergoing surgical procedures, planned pregnancy with obese mother, systematic screening for family members not recommended at this time. Further workup, incidental finding on imaging for some other reasons, abnormal liver enzyme, symptoms of liver disease, rule out other causes of alcohol, medication, hepatitis, etc. Less than 1.45 predictors or absence or significance of fibrosis, 1.45 to less than 0.6 intermediate score, and 0.67 or more is the predictor of presence of significant fibrosis. Liver biopsy, the incidental finding on imagery with normal enzymes, no biopsy is indicated, just monitor. Presence of metabolic syndrome and persistently elevated biochemistries may benefit from liver biopsy. Patient with biopsy-proven NASH cirrhosis should be screened routinely for esophageal varices and HCC. The symptoms, the malaise, fatigue, right upper quadrant discomfort, snores, disturbed sleep, wakes up tired, chronic pain, disorders, and achy. Physical exam, abdominal obesity, enlarged liver, right upper quadrant tenderness on palpation, labs consistent with metabolic syndrome, elevated bilirubin, AST, ALT, AP, and GGT. Lifestyle intervention, weight loss by lower caloric intake with increased physical exercise led to improvement in biopsy. 9.3% weight loss improvement in steatosis, necrosis, and inflammation and fibrosis. 3 to 5% weight loss improved with steatosis, but more is needed to improve the inflammation. Alcohol consumption, heavy intake should be avoided. Light intake may have benefits or may not. Insulin sensitizing agent metformin reducing in IR and enzymes, no improvement in histology. Rosiglitazone improved enzymes and steatosis but no inflammation. Pioglitazone weight gain but improvement in hepatocellular injury. So, Pavin's study shows pioglitazone, vitamin E placebo, and 96 weeks adults with NASH without diabetes mellitus, cirrhosis, hepatitis C, and heart failure, limited alcohol intake over the period of 5 years, randomized trial. Recommendation is PIO can be used to treat certain patients with biopsy proven of NASH who do not have diabetes mellitus. Other medications including ursodeoxycholic acid, no histological benefit, omega-3 fatty acid effective in treating hypertriglyceridemia in patients with NAFLD, evidence of treatment of NASH inconclusive to date, and large multicenter trial is ongoing now. Statins, CVD, common cause of death for NAFLD and NASH, stratify the risk and treat accordingly. Several studies show NAFLD and NASH patients are not at increased risk of liver injury over general population. No RCT with histological endpoint using the statins to treat NASH. AASLD recommendations on statin. Given lack of evidence that patients with NAFLD and NASH are at increased risk of serious drug-induced liver injury from statins, and they can be used to treat dyslipidemia in patients with NAFLD and NASH. MS and immunosuppression. Steroid increases the blood pressure, induce IR, lipid metabolism, weight gain, increased gluconeogenesis, decreased peripheral glucose utilization, CNI, pancreatic beta cell toxicity, nephrotoxicity, TAC, glucose intolerance, and de novo diabetes mellitus, CSA, hypertension and hyperlipidemia. mTOR inhibitors cause hyperlipidemia. Metabolic syndrome and kidney transplant. Metabolic syndrome may play a role in allograft loss and poor function. Pathophysiology of MS is altered by immunosuppression. Risk factors for NASH and fatty liver transplant, post-transplant obesity, TAC-based regime, diabetes mellitus, hyperglycemia, hypertension, ETOH as the primary cause for transplant, pre-transplant allograft biopsy showing steatosis. MS post-liver transplant, diabetes post-OLT, 5-year occurrence of the advanced fibrosis is increased in patients with treated for diabetes mellitus when compared to those with normal insulin sensitivity. Treatment goals are same as general population. MS post-liver transplant, dyslipidemia post-OLT, changing immunosuppression from CSA to TAC and RAPA to TAC, steroid-free. High cholesterol, statins, pravastatin is most studied, does not require P450 enzyme system with other statin reductions of TAC and CSA dose, Mediterranean diet, high triglyceride fish oils, phenofibric acid derivatives reduction in TAC and CSA doses, and azitamine. MS and heart transplant. 48% of the heart transplant recipient long-term survival benefit without MS. Difference of observed and MS group. Median old age, pre-tax creatinine higher, and pre-transplant hypertension is higher, BMI is higher, dyslipidemia is higher grade. No difference in MS versus non-MS. Gender, underlying etiology, smoking, diabetes mellitus, history of pre-transplant immunosuppression. Impact of FLD on donors, death due to CVA and CVD results in atherosclerotic vessel, poor quality organs, fewer organs, discarded livers with 30% steatosis. Acute fatty liver in pregnancy presents in 35 to 36 weeks of pregnancy, mitochondrial dysfunction preventing the oxidation of FFA with accumulated in the liver, present with malaise, nausea and vomiting, third trimester, right upper quadrant pain, upper GI bleeding, ARF, FHF, confusion, hypertension, jaundice, hypoglycemia, mortality rate 12.5 to 18% infant and 7 to 66% postpartum, may resolve or proceed in needing a transplant. Pediatric issues, NAFLD reported as early as 2 years, NASH-related cirrhosis as early as 8 years. Independent predictors of FLD in adolescents, obesity, older age, male gender, dyslipidemia, Hispanic ethnicity, hypertension, and IR. Children are very young and not overweight who have NAFLD should be worked up for other causes of liver disease, alcohol, inborn errors of metabolism, storage disorders, Wilson's disease, autoimmune hepatitis, cystic fibrosis, viral hepatitis. Expert panel recommendations: biannual AST/ALT starting at age of 10, obese clinical and those with BMI more than 85 percentile with other risk factors, and AASLD has no recommendations. Prospective intensive lifestyle and behavior modification improves ALT and steatosis by ultrasound. More than 20% of body weight reduction, 94% are able to lose weight by calorie reduction and exercise. RCT shows antioxidant therapy groups are lifestyle modification alone, lifestyle modification with vitamin E and vitamin C. Both groups improved ALT, steatosis, inflammation, ballooning equally. Concluded no advantage of adding vitamin E and C to lifestyle modification. Tonic study: vitamin E or metformin, 8 to 7 years old with NAFLD. Primary outcome: sustained reduction of ALT, not achieved in either group. Statistically significant improvement in resolution of NASH in vitamin E group over placebo. Metformin offered no benefit over placebo. Intensive lifestyle behavioral modification include dietitian consultation in first-line treatment. Metformin 500 mg BD offers no benefit. Vitamin E 800 international unit offers histological benefit, but confirmatory studies are needed before it can be recommended in clinical use. Thank you.